But we're really excited to offer you guys the PROstep refresher course. Dr. Eric Baskin is going to be speaking to us tonight on minimally invasive solutions of the forefoot, specifically some Hammertoe and DMMO options for us. And I will pass it off to him, and he'll take us through the slide. If you guys have any questions, feel free to use the chat function, and then we'll try to open it up to attendees on the back end of it for any questions regarding the presentation or any other PROstep procedures.
Thank you, Jen. I appreciate it. I appreciate the invite and the interest from all our attendees. This is a great topic, one of my passions in terms of foot and ankle surgery, and hope I can bring you along the path that I've come through. We were all familiar with the MICA procedure, and it's just got back from ACFAS, and so just a tremendous interest all around in MICA and also in minimally invasive surgery in general. And so I'd like to keep the groundswell going, and I'd like to keep the momentum going, and share with you what I've been doing over the past 6-7 years, and see if there's any questions at all regarding this, and bring you along my journey into this revolutionary form of surgery. So just to start out, my disclaimer. So as I was saying before, bunions, that gets all the glamour, gets all the attention. But there's so much more that can be done with MIS. Plantar ulcers, hammertoes, metatarsalgia, arthritis hallux limitus, bunionette, calcosteotomies, Haglund's, and now Charcot. So there's a lot of other uses besides just the MICA. To quote David Redford, the bunion surgery minimally invasively is evolutionary, but things like hammertoes and metatarsalgia is revolutionary, and I agree with those sentiments. And so that's brings me to the beginning of my MIS journey and what started me along this path. And basically, hammertoes is what kind of got me on this track. Hammertoe surgery, initially open techniques, performed the way I was taught, the way it's in the taught in the residencies, the way it's in the textbooks. Over the past 30-40 years, I was performing the same way, and I just was not getting the results that I was trying, that I wanted. From a didactic standpoint, from my x-rays, everything went well, but the patients were unhappy, and I was unhappy with that, but because I wanted to satisfy the patients, not just have a good x-ray. And so on the left, you look at the traditional repair, and the toe is very straight, stiff, and much longer than the other toes. So here I performed the traditional surgery that's in the McGlamory's books, and although radiographically and even from my perspective at the time, this was a success, the patient was extremely unhappy with the way it came out. She didn't have pain, but she said, "This doesn't really look like a normal foot to me," and it doesn't. And so the patients wasn't happy, and that's really all who matters in this scenario. And so I started to look elsewhere and look at other options, and I started using absorbable fixation. I started using joint implants. I started trying not to use any K-wires. I tried every possible way available in the United States at the time, and I still wasn't getting to where I needed to be. And then I came across some of the literature from Europe, primarily from Mario Di Prato, and a lot of the joint dissections and a lot of the cadaveric dissections was showing how they were doing it minimally invasively. And at the end of every journal article, if you read, you'll always find the email address of the author. And so through emailing and networking, I came across some teachings, some lectures, and ultimately some cadaver labs And that's what started my journey. So traditionally, Hammertoe surgery open is joint destructive. There's hardware involved. Primarily, it's painful. It's very painful. Some patients will say that the Hammertoe surgery was worse than their spine surgery. It's unpredictable, and although it may relieve some of the pain, the patient doesn't always like the way that it looks, and the patient satisfaction level is not always that high. And so that's what kind of led me again to this other form of surgery, as you could see, as much more of a natural look, functional look. We preserve the joints. The pain is a fraction of what it is open. And in my hands and my experience, is no question that this is revolutionary, and this is really, in my hands, the way to go. So the Hammertoe technique formula by Bernard Redford and Foot and Ankle Clinics 2016 basically is for, I would say, 90% of Hammertoes, my procedure to go to, where you do a tenotomy and capsulotomy. If you look at the metatarsal flange joint above metatarsal, you're going to release the extensor tendons. You're going to then also release the extensor capsule, or the dorsal capsule, the metatarsal flange joint. And then you're going to eventually come plantar, and you're going to release the plantar tendons, the flexor tendons, and then perform a plantar closing wedge osteotomy of P1 or the proximal phalanx. You're going to make a separate incision medially and perform a dorsal wedge osteotomy as well. And if necessary, perform another FDL tenotomy. More advanced techniques involve releasing only the flexor digitorum brevis tendon. However, in my experience, in an older patient, you must release both of the tendons. I've found the recurrence if you just release the FDB. Younger patients where power and strength is more of an issue, then I tend to go more with the flexor digitorum brevis isolated tendon release. So this Hammertoe technique formula is essentially my go-to for the majority of Hammertoes that I perform, and I found a lot of success with it. So there's several different things that you can do to treat Hammertoes. Hammertoe MIS is joint sparing, so you don't remove the joint, you don't fuse the joint, and so there's still motion left most of the time, unless it's a severe deformity. Sometimes they can stiffen up in the corrected position, but primarily they're still joint sparing. You can correct in all the planes, including transverse. You don't have to do tendon transfers. You don't have to do all this fancy work to get the toe to move transversely. You can create a bicorrectional wedge osteotomy to create correction both in the sagittal and transverse plane. And the toes are left with a much better functional cosmetic appearance without hardware, and a much natural look to them. Also, if for some reason the surgery doesn't go as planned, you're in your learning curve or technical issue or not compliance issue, you didn't burn any bridges, because if you need to go ahead and do a fusion or an arthroplasty, there's no incision to fight, or previous incision or any previous scar tissue to fight. So you don't burn any bridges with this procedure. Here you can see in this particular patient who suffered from crossover toe as well as severe metatarsalgia, I performed both osteotomies of the proximal and middle phalanx, as discussed before, as well as the soft tissue work. But to correct the metatarsalgia, I performed what's called DMMO, or distal metaphyseal metatarsal osteotomy. And that is the minimally invasive equivalent of a WOW osteotomy. And you can see no hardware was utilized. The ground reactive forces basically repositioned the metatarsals to an anatomic parabola. And with the use of taping techniques, we were able to maintain the Hammertoe correction. Here you can see this is a tenotomy capsulotomy. And this is after, on the right, the puncture incision, followed by the release of the flexor tendons. And then through that puncture incision, we're able to utilize a burr to create that plantar flexury osteotomy. And you can see here, again, this Hammertoe technique formula being utilized. Here's another example. This is an older osteotomy prior to MICA called the Revirden Isham procedure. It's essentially a minimally invasive Revirden type procedure and an Aiken. But the important thing to realize is both the DMMO osteotomies and the Hammertoe repair, and you could see that a fairly severe deformity that open would be really a headache and difficult to perform, is relatively easy and powerfully effective minimally invasively. You could also see there was a Taylor's bunion that we also addressed as well. So the DMMO, you could see here, it's just the equivalent of a while. However, I will say that in general, I perform the osteotomy about slightly more proximal than what's in this picture. However, this is the traditional technique that is very reproducible. And you can see it, once you make the osteotomy, it moves both proximally and slightly dorsal. And that corrects for some of the abnormal metatarsal parabola, which helps with the transverse plane deformities in the Hammertoe repair, as well as gives some slack with the Hammertoe repair. But it also will take the stress off the plantar aspect in the event that there is metatarsalgia. So we need to perform usually 2, 3, or 4, or 2, 3, 4, and 5, but it's extremely rare, 1% in my hands, that I ever perform an isolated metatarsal osteotomy. You're just begging for a transfer metatarsalgia or transfer lesion. So it's also fairly rare that I just do 2 and 3 unless I have an absolutely perfect 4th metatarsal position. So I traditionally will do 2, 3, and 4 most of the time. I'm just going to go back to this here. I would caution it to do this DMMO procedure only when it's absolutely clinically indicated. There's a very high potential to be overutilized, and I would never use it in conjunction with performing a MICA unless you're extremely well-versed and experienced, because if it's not done properly and you perform it with a bunionectomy, you will get a reoccurrence of your bunion. You will increase unintentionally the IM angle, because the metatarsal heads have a tendency to shift laterally. So in the beginning, when you're getting the feel for this and going through this learning curve, do not combine them with a MICA bunionectomy. They also have a tendency to take a long time to heal, and you need to consult with the patient and consent with the patient that one of the drawbacks to this procedure is that it can swell for 3 to 6 months, sometimes even up to a year. It is very, very high gold standard potential in neuropathic patients with neuropathic ulcers along the plantar aspect of the foot. It is extremely atraumatic, it's easy to perform, and is extremely effective. This is a patient that we all have in our practices where a digit was removed from gangrene, and it overloads the other metatarsals, specifically the second. You can see an ulcer that is formed there. The old technique standard was to perform a metatarsal head resection, but you're just kicking the can in that situation, because you're going to get the transfer lesion over to the 3rd metatarsal and then the 4th metatarsal. So to perform a DMMO in this patient, 2, 3, 4, even 5 if necessary, is extremely effective, because you walk them right away, and the ulcer typically may have been there for a year or 2, will heal within 2 to 3 weeks, even with full weight bearing. It's a very dramatic healing effect, and it's a very, very powerful procedure. You can see what we did here. We left 5 alone, but we also addressed some of the Hammertoes as well, and we performed DMMO, and this is literally 2 to 3 weeks post-procedure. It's amazing how fast these heal. You can combine this if you need to with a gastroc recession, and now you got a really good thing going on. But I would caution about doing just a gastroc recession on everybody, because the DMMO procedure is so powerful. Here you can see on the bottom right, we were able to correct for the Hammertoes as well to prevent further ulcers down the road. Here's another patient, similar presentation, who has fairly thin, poor skin. And he had this ulceration for many years. and went to hyperbaric oxygen, was in and out of wound care centers, and no one operated on him, and rightfully so. The skin is just it's just not surgically conducive skin. I would not recommend a gastric even recession unless you're very atraumatic because of the skin and the vasculopathy that the patient had. So once optimized, the DMMO just makes a lot of sense. And here you can see after performing the DMMO osteotomies on this patient, just a little bit of remnants, mostly protective callus that's formed there. You can see pre-op, you can see the metatarsal parabola issue as to why he had the ulceration there. And this is immediate post-op. So very, very powerful procedure in the neuropathic diabetic patient. There's even some backup literature from Israel. Nice size study, and more and more literature is now being published in the United States. As far as that very stubborn ulcer underneath the metatarsal head, rather than perform a Jones-Tino suspension or hopefully not a Keller procedure in this situation, but or you could avoid doing a Jones or a dorsiflexory osteotomy if it's not rigidly plantar flexed by performing what a sesamoid shave percutaneously. It's very easy to perform. It's very traumatic. The patient can walk right away. And you can see on the left, the post-operative, the preoperative on the right, and how effective it is. Again, these heal within 2 to 3 weeks after the procedure. And you can see this is what pre-op on the right, post-op sesamoidal axial. On the left, you take about 1/3 to 2/3 of the sesamoid out through a grinding using a wedge burr. However, you still maintain the function. It's not like a sesamoidectomy. You still maintain the function of the sesamoids to prevent things like cock-up hallux, drifting medially or laterally. So it's another simple, powerful, atraumatic procedure, which is really the tenets of some of these really successful minimally invasive surgical procedures. Taylor's bunion, for a lot of surgeons taking on minimally invasive surgery, this is by far their most favorite procedure. It's fairly easy to perform. It takes about 30 seconds, and it's extremely powerful. It's essentially painless. The patient can walk right away, albeit you have to perform it correctly. It's not foolproof and does take a certain amount of skill level, skill set, and experience and learning curve. But that being said, I haven't performed an open Taylor's bunion in probably a good 5-6 years. So great procedure. Here's another example. It's a great also if the patient has a plantar callus or plantar lateral callus, because you get a little dorsiflexion as well as some transverse plane correction as well. So there are two techniques. One is a simple metatarsal head osteotomy, almost like a Mika without the chevron, more of an oblique cut, almost like a Mao bunionectomy. You can see pre-op and post-op, just a touch of elevation. And you can see the pre and post-op. This one happened to have a callus there. And you can see that on the left side, the transverse plane correction, and the right two large photos, the sagittal plane correction. For larger IMs, this is the go-to technique, really perfected by the European minimally invasive surgical group, now known as MIFAS, starting out as Gretmick. But you're going to do a closing wedge osteotomy, leaving a lateral hinge at the level of the diaphyseal metaphyseal junction. You're just lateral to the tendon, and it's performed fairly effectively in this situation. A lot of times also you can make a separate incision and actually perform an exostectomy. And you can see in this particular specimen and the cadaveric specimen, as well as on the live specimen or live surgical specimen, that there was a second puncture incision to take down the exostosis. Again, very 45 angle technique, both dorsiplantar as well as lateral to medial. and very effective technique. You can see in this particular patient where very severe deformity, large callus along the plantar aspect of the left foot. And you see pre-op and post-op, just how effective it is. We performed an exostectomy at the same time, as well as a forefoot reconstruction. You can see the DMMOs as well that we performed. If you see, I do perform a while on when the joint is severely contracted or dislocated. You can see just how severe this deformity was preoperatively. So an alternative to what we were discussing with the traditional minimally invasive techniques is a nice little plate that was developed. This is really interesting. Here you can see it's got some rigid fixation for those patients that are fairly non-compliant, who do too much walking, which you can do with minimally invasive surgery, as well as maybe the surgeon was not necessarily 100% all in on MIS techniques. This offers a little bit of a happy medium. Here you can see this is one of the few circumstances where I did not perform a DMMO on the fourth metatarsal, because you could see that fourth metatarsal position is actually right where it needs to be. So we did that. We performed it on the second and third, and then the Taylor's bunion in the fifth. And you can see that this is completely healed. The fifth metatarsal is completely healed at about 6 weeks. And you can see that the second and third metatarsals are still, osteotomies are still healing. There's still bone callus that's being formed. And even the proximal phalanx osteotomies are not healed yet. So just to show you how stable that fixation is. So nice plate. You can see the correction here. Same thing. This is completely healed. These are still healing. Metatarsalgia with crossover toe. This is like the greatest gift, in my opinion, that MIS has to offer the surgeon as compared to open techniques. You just can't get this type of correction open. It's just so, the results just come out really, really nice from both the functional and cosmetic approach. This is that same procedure I discussed before. It's a fairly dramatic repair, and that's why I like to show it. But you don't have to have, not every hammertoe has to be this dramatic. A simple hammertoe it works just as well as the severe hammertoe deformities. But you can see in this particular patient, if you look at the second proximal phalanx, we did open it up a little bit. We did create some transverse correction there, as opposed to traditional sagittal plane. And here we talked about hybrid. This is a fairly severe deformity that we corrected. But if you look at the second metatarsal, it is severely contracted, dislocated, and actually the cartilage has adapted to a position articulating on the dorsal aspect of the second metatarsal head. When I did, you can't fix that minimally invasively. When I did open it up, I actually had to remodel the base with the burr because it just was not a functional joint at that point. And you can see the second digit at the base. So part of the cartilage is intact, but part of it I had to burr down in order for it to sit properly. You can see that we performed also DMMOs of the third and fourth metatarsals, as well as osteotomies. You could see though, because I'm fairly experienced in the MICA and so forth, and we did fixate this, that I would perform the DMMOs. However, if I was just performing the bunion this severe without the contracture, and I would probably avoid performing the DMMOs on the second, third, fourth metatarsals for fear of reoccurrence. And you can see on the lateral view, very powerful correction with this technique. Here's another example. Again, very osteoporotic bone, severe deformity. You just can't correct that second digit with MIS, at least in my hands. There may be some Europeans that have heavy experience that may be able to, but in my hands, a small incision makes a big difference. The rest of the procedure, both the hammertoes and the proximal phalanx, and the other DMMOs were all performed minimally invasively, and obviously the hallux valgus repair. You see how, how functional, how powerful this correction is. Neuroma. So I've had some interesting discussions with some of the experienced users in the minimally invasive community, both podiatrists as well as orthopedists, and most of us are in agreement that neuroma may be a little over diagnosed, and that a lot of times when it's diagnosed as a neuroma, it's actually metatarsalgia or even capsulitis. This could be extremely detrimental to the patient, especially if you perform a neurectomy and the pain is still present, coupled with the fact that 2-3 years later, high incidence of stump neuroma, you have a pretty miserable patient. Typically what I will do is I will do a DMMO procedure on 2-3 or 2-3 and 4, and then at the same time I will release the deep transverse metatarsal ligament to perform that neurolysis. They did a study for these type of procedures, and substantially less opioids with this than the traditional neurectomy. You can see here is a kind of a diagrammatic model of how you, after doing or before during the DMMO, you would do that release of the deep transverse metatarsal ligament to allow that nerve to kind of breathe, so to speak. So there are other types of osteotomies as you start to develop experience. I don't recommend these right off the bat, but as you start to develop increased experience in this, besides the traditional DMMO, which is shown right here, you can do a DICMO, which would be intracapsular, excuse me. If you're afraid in the situation where you're doing a hallux valgus repair of reoccurrence of the lateral translocation of the second digit, or you could do a DOMMO for severe deformities. You could actually get up to a centimeter of translation, either proximally or medial-laterally with the DOMMO, and I'm going to explain some of that in the future of this talk. But there are 3 different types of metatarsal osteotomies, and that's where this kind of really gets interesting. So here's an example of where we kind of use all 3. A very complex deformity, both hallux valgus. The 4th toe is being driven by both the 5th and 3rd toe into the ground. There's a large IPK, submetatarsal head 3. And if I were to treat this open, it would be quite an adventure. However, minimally invasively, this is fairly straightforward and easy to perform. So you can see here, again, on this view, quite a little headache ahead of you. The x-rays aren't pretty either. The patient was extremely understanding, enthusiastic about the procedure, and had a great result. You can see that in terms of the initial preoperative, postoperative x-rays, we performed a MICA, as well as if you look at second metatarsal, there's an intracapsular DICMO, as well as a DOMMO in the 3rd metatarsal. The 4th metatarsal was in a great position, so we left it alone. And obviously the Taylor's bunion deformity and Hammertoes as well. You could see that we were able, with the DOMMO, to move that metatarsal laterally while keeping the second metatarsal without that translating laterally. You have to be very careful when you do an intracapsular osteotomy to go very slow with the burr so that you'll develop an avascular necrosis. So here you can see pre and post-op at the 4th digit is now viable again, and it sees the light of day, and just a very functional, happy patient. You can see the IPK is also gone. The 4th digit is in the correct position. And just a great overall result. Also, plantar plate, I think, is also a hot topic now, but in grade 1 tears, I've found good success with just performing DMMOs. To prevent any lateral translation, you can see I did the DOMMO on 2 and 3, and 4 I did the traditional DMMO. But the same process occurs if it's not ruptured. you can perform the DMMO, and on the same time, to prevent the floating toe, you can perform, here you can see a plantar flexural osteotomy of the proximal phalanx. And here you can see the left foot is the same. The left foot is the foot that it was not operated on, but that's what it looked like beforehand. You can see that she's favoring the MPJ plantarly, but the right foot is the one that we operate on, and much more functional. So post-op, part of the correction is full weight bearing. So we would have the patient's full weight bear immediately in a post-operative sandal. I would avoid the cam walkers because they can't decelerate the foot as like they can with a surgical shoe, because the boot is fixed. Specific dressings, which are beyond the scope of this talk, but you were going to perform specific dresses for 3 weeks. You're going to elevate for the first 2 weeks, and then at 6 weeks, we tend to go back to full activities. The DMMO can also be used in severe metaductus. Here's an example of a patient that had severe deformities. We were able to perform the lesser metatarsals minimally invasively while performing adjunctive procedures. There was actually a poster that was presented at an ACFES meeting. And I also presented this case at the International Minimally Invasive Surgical Meeting. Here you can see that there's other issues going on. There's a calyx foot, there's a hindfoot varus. And so some of this that I would perform now minimally invasively, at the time I performed open, such as Dwyer osteotomy and perineal longus tendon repair, gastric recession. But that didn't, we staged a procedure. The second stage, we still had a lot of work ahead of us. And so with the history of rheumatoid arthritis, we wound up fusing the great toe to prevent reoccurrence. I performed the mini open proximal chevron osteotomy and a fifth metatarsal osteotomy open. But we performed the DMMOs percutaneously, and you could see how much correction you can get with both shortening as well as lateral or even medial, if necessary, translocation. It takes a little bit of a leap of faith, almost like when you're doing a breaking med or a limb lengthening or what have you, as the initial x-rays look a little frightening. But as you can see, basically with the principles of this type of surgery, you essentially leave that periosteum intact, and over time, the ground reactive forces place the metatarsals exactly where they need to be. And you can see over time that healing taking place, all the while full weight bearing. You can see pre-op, immediately post, I'd say about 6 weeks after we remove the wires. This is about 6 months. You can see there's contractures in the lesser digits because of pain from the plate of the fifth metatarsal. And once we remove the plate of the fifth metatarsal, you can see things kind of got back down to normal. So I hope I explained sort of my thought process into doing some of the lesser metatarsal distal forefoot surgery, and I hope your journey is as enjoyable as mine has been, and your patients will be happy. Your patients will thank you for this, as in my hands and my experience, this is the best way to address this pathology.
Perfect. Thank you, Dr. Baskin. I didn't see any questions come through the chat, but I did want to let everybody know that this presentation has been recorded, and we will definitely be posting it to our PROstep surgeon page. And then we also have 3 more PROstep refresher courses coming up this year, as well as some additional PROstep regional labs that you guys absolutely can sign up for. So thank you guys. We appreciate you joining and hope to see you next time.